going to be more in-depth, building upon that. And that being said, I also did this every day for 6 years. So I'm going to talk about it in 2 hours. But we're going to go through everything. And I will also say that the guidelines for heart failure change pretty frequently. These are the most updated ones that will likely be on your board, but just know that like these are forever changing. There's new data all the time coming out. Okay. All right, so we're going to start by defining what a cardiomyopathy is. So when we talk about cardiomyopathy, it literally means cardio, heart, myopathy, disease of the muscle. So it's any disease of the heart muscle, the myocardium, that's characterized by either structural or functional abnormalities that can lead to mechanical or electrical dysfunction. And there are certain categories that are the most common that we're going to talk about today. So ischemic cardiomyopathy, we kind of talked about that when we talked about coronary artery disease, STEMI and STEMI, right? We kind of touched upon that, like your EF can drop, you can have wall motion abnormalities and changes. It's kind of a category of its own. Then we have the non-ischemic cardiomyopathies, which are dilated, hypertrophic, restrictive, and stress. Have you guys heard about these yet? Yeah. Sort of? Just like sprinkled in somewhere? Yeah. We're going to get into detail of those. So this is how I want you guys to organize it in your head. There's a lot of categories in heart failure and cardiomyopathy. So ischemic cardiomyopathy is defined as left ventricular systolic dysfunction in the presence of significant coronary artery disease. So usually the ejection fraction will be less than 50%. So there's systolic contraction issues with documented significant coronary artery disease. Now, what counts as significant coronary artery disease?
Like 70%.
More than 70%, close. Exactly. So that's considered significant. So if someone has a cardiomyopathy and you do a cath and they have like 30 to 40% blockages, it's not enough to cause muscle damage. So that wouldn't be the primary cause. So significant coronary artery disease. The risk factors are going to be exactly the same as the risk factors for coronary artery disease that we chatted about already. So older age, males, smoking, hypertension, diabetes, hyperlipidemia. And the pathophysiology are, you have coronary artery disease, which leads to ischemic cell death. The left ventricle will begin to remodel, and then eventually we get a decreased function of the heart, usually systolic.
That's 50%.
Yes, exactly. So myocardial stunning is something that can happen when you have a STEMI or an NSTEMI and you have acute decrease of blood flow to the myocardium. And then upon reperfusion, the myocardium is stunned. It's like almost like traumatized as to what happened. And even though there's blood flow going to that area, it still won't pump as efficiently as it should. So myocardial stunning usually happens after a big MI, and it will usually recover once enough time has passed with blood flow back to the heart. Myocardial hibernation is a little bit different. This is, I'll tell you guys a scenario to put it into perspective. So usually we see this if somebody has like a chronic 70% lesion and we do a stress test, it shows that they have like significant ischemia to that area. We take them to the cath lab. We inject dye. We see, okay, yeah, this is like a 70 to 90% blocked artery. And then we have to see if the myocardium is still viable, right? Because there's a certain point in time where that wall of the heart doesn't get enough blood flow that it infarcts. Ischemia usually has myocardial hibernation, which means that the myocardium isn't working properly, but if you restore blood flow, it will improve and get better. That's myocardial hibernation. And ischemic cardiomyopathy resembles what we're going to talk about with dilated cardiomyopathy. They look very similar. The main caveat is that one has significant coronary artery disease, the other does not, and is usually a genetic component. These are going to present with dyspnea on exertion, fatigue, chest pain, edema. Think coronary artery disease symptoms and heart failure symptoms. This can both present as. The EF will be less than 50%, and the echo finding we're going to see are regional wall motion abnormalities. Why are we going to see those?
Remodeling?
Close. Not remodeling yet. So regional wall motion abnormalities, like we talked about with STEMIs and NSTEMIs, just means that one specific region of the wall isn't moving as it should. So you'll see like akinesis, hypokinesis of the wall because it's not getting blood flow. And that's correlated with the certain arteries of the heart, right? LAD, anterior wall. So that kind of will tip you off that it might be ischemic in nature. Secondary mitral regurgitation or ventricular arrhythmias or heart failure symptoms. And just to remind you guys, secondary mitral regurgitation happens because the LV dilates, which pulls the mitral annulus apart, and that can cause some leakage. We diagnose this with echo, or it could be any other test to confirm EF. We're going to get an EKG. We're going to get a cardiac cath, plus or minus a viability study. So the viability study tells us if the myocardium is worth saving. So if somebody has like a 90% blockage and they have a negative viability study, that tells us that even if we opened blood flow back to that portion of the heart, that heart wall is not going to recover. The tissue's dead already. And that's important to know because even though the cath is not as invasive as open heart surgery, it's considered a lower risk procedure. It still has risk. So we want to know if it's worth taking the risk, worth trying to fix that artery. And then the treatment for this is guideline-directed medical therapy. Dr. Halimi said you guys touched upon this, right?
Yeah.
And there's a more detailed slide as we go through this, and we'll talk about it again, but just think about those 4 pillars. We're clumping them together. Guideline-directed medical therapy is going to help with ventricular remodeling and decrease the neurohormonal pathway. Did you guys talk about that yet? Excellent. We're going to talk about it today. So we'll put a pin in that. You're going to see GDMT over and over for the treatment for cardiomyopathy, heart failure, but we're going to talk about that in detail a little bit later. See if they're a candidate for revascularization. So this could be stenting or CABG. The indication for CABG usually is if someone has left main disease, that is too risky to go in and stent. Do they sometimes do high risk left main stents? Yes, in specific cases. The problem is if something goes wrong in the cath and you occlude the left main, the entire heart is not going to get blood supply, right? That's the first pipe that comes off of it. So it's not beneficial to stent that area unless it's like a very specific situation. So left main, multi-vessel disease. Usually if there's 2 or more significant vessels that are usually like over 70% blocked, you'll do a CABG. And diabetics. They have an extremely high rate of restenosis if you stent them. So doing a CABG, someone with significant coronary artery disease and is diabetic, they usually go for CABG, not stenting. We're going to treat their coronary artery disease, aspirin, statin, risk factor modification. And then for ejection fractions less than 35%, what's that? Oh. And that's it. We're done with the information. That's all you need to know. Oh, that was fun. Maybe, no, I don't think I hit anything. It's the cardiac gods up there saying, blinking at it. So, device therapy. Patients with cardiomyopathies and ejection fractions under 35% may be a candidate for internal cardiac defibrillation, right? We chatted about that. It's the pacemaker with the big coil at the end that has the potential to shock someone out of ventricular arrhythmias. If someone has a cardiomyopathy or an EF less than 35%, they are at a higher risk of developing VT just because of the EF being that low. So it's kind of an insurance policy to say, okay, you may never have VT, but you might. And if you do, here is the defibrillator to shock you out of it if it does. Chronic resynchronization therapy, we're going to talk about when we get into heart failure, is a specific type of pacemaker defibrillator that resyncs the heart for both ventricles to beat together. So put a pin in that. We're going to talk about that more when we talk about heart failure treatment. And then we have something called an LVAD or a transplant if this is end stage advanced disease. So if they have really bad heart failure, we're going to go through the stages of heart failure. Usually it's stage D. And they failed medical management. We tried to open up the artery that's not working. We put them on guideline-directed medical therapy, and their ejection fraction isn't improving, or they're not able to be on the medications anymore because they're becoming hypotensive. That's when you send these patients for a heart transplant. An LVAD is a device that it's basically like a bypass that you could walk around with. They cannulate the heart from the apex, and then there's a tube that goes out of the abdomen, and they wear it like a backpack. They have a battery that is keeping their heart pumping. So if you check a blood pressure on them, you can't get a systolic and diastolic because it's just circulating the blood for them. And this can be a bridge to a heart transplant, like if someone's waiting, or if they're not a candidate for a heart transplant, it's palliative. So this is just helping their symptoms or buying them a little bit more time. And the LVAD patients are pretty crazy because they're at risk for a lot of complications like stroke, infection, and then they actually have to notify PSEG if their power goes off. They're the priority because they have to plug themselves into the outlet and charge like every night for the battery. So these patients are sick. If you get to end stage heart failure, cardiomyopathy, they are mortality rates high and they're very sick. So that's ischemic cardiomyopathy. The take homes are they're going to present like coronary artery disease patients, plus or minus some heart failure symptoms. Their EF is going to be less than 50% with maybe regional wall motion abnormalities on echo. They're going to have significant coronary artery disease that's causing the dilation of the ventricle and the remodeling. And this is kind of a nice visual of what remodeling happens after an acute MI, which we kind of touched upon in, I feel like, the STEMI lecture. So you're going to have infarct expansion over time if there's inadequate healing after the MI. The LV is going to get more dilated. The myocardium is going to get thinner, and they develop heart failure symptoms like congestion, JVD, leg swelling, shortness of breath, stuff you guys have heard already. Any questions on that one? So the next category we have is something called a dilated cardiomyopathy. So the definition of this is left ventricular or biventricular dilatation with systolic dysfunction without a reason. So you can have remodeling changes from coronary artery disease, like we said, but you can also have it from primary valvular disease and hypertension. Dilated cardiomyopathy is when it's dilated and it has none of those reasons. So it doesn't have like severe mitral stenosis that's causing the dilation. It doesn't have uncontrolled high blood pressure that led to like thickening and then dilation. That's the caveat with this one. So LV enlargement, EF less than 50%. And the etiology for this one is usually genetic. So there's over 50 identified genes associated, but like we said, this is always changing. They're always doing research on this. So by the time you guys are like well into your careers, it's probably going to be a lot more. There's a certain one genetic mutation that carries a higher risk of conduction disease and sudden cardiac death. So that's why genetic disease testing is so important in these patients, because you want to know that in case they need a defibrillator if they have one of these high risk mutations. And also you want to test the family members, right? If it's hereditary, you want to get the family members genetically tested, get an echo on them as well for screening. And then there can also be some acquired causes, infectious. So viral myocarditis can cause this. Dilated cardiomyopathy, Chagas disease. Do you guys remember what that is? The parasitic infection in South America can cause a dilated cardiomyopathy. There is toxin induced. So alcoholics can get a dilated cardiomyopathy, cocaine use, some chemotherapies, specifically anthracyclines, methamphetamine. So do you think that when someone comes in with a dilated cardiomyopathy, we're going to do a lot of drug screening as well, right? We're going to do genetic drug screening. We're ordering everything on the menu. Endocrine, so uncontrolled hyperthyroidism, hypothyroidism, pheochromocytoma can cause these changes. Peripartum can also cause this temporarily. Have you guys heard of something called tachycardic induced cardiomyopathy? Excellent. Well, you heard it here first. So if someone has a sustained rapid arrhythmia, it can actually like fatigue the heart enough that the cardiac output diminishes. So an example that we could talk about, because we know AFib already, if someone has chronic rapid AFib, sometimes they like say they've been in it for like a week and they're just coming to the hospital now and their heart rate's been like in the 120s, 130s. And they've had it for like a week or two. We get an echo, we may see that their ejection fraction is like 40%, 35%. And that's because the myocardium is getting tired. It's been beating at 120 beats per minute for so long. It can only sustain that for so long until it kind of starts to poop out. Usually reversing that cause and giving them some guideline directed medical therapy, they'll recover pretty well. The more quickly you correct it, the more likely the heart's going to recover. Yep.
What's like the duration that you be like your tracking? How long until they get the dysfunction?
So that's a great question because it definitely depends. I've seen it a bunch of ways. For rapid AFib, I've seen people present like a few weeks of it and they have it. And I've also seen patients where they go into rapid AFib, they feel terrible, and you get an echo at that time when the heart is rapid and they've only been in it a few days, and it's the EF is low because the heart rate's so fast, and then you cardiovert them the next day, their EF is normal. So it depends on the patient. The take home I would say is that the longer you're in it, you're decreasing your chances of the myocardium recovering. So say like someone has AFib, intermittent rapid rates for like years, those changes to the heart may be more permanent than someone that came in for like a week and it's brand new and then we corrected it. Yep.
What does recovery look like? Is the heart going to go from dilated to normal size? Will it just have a better ejection fraction?
Yeah, so that's a great question. So how we treat these cardiomyopathies is the goal is to help take the stress off the heart to allow it to recover to normal function. Sometimes if a myocardium is so dilated, if you guys think about it as like a rubber band being stretched so many times, like it will keep coming back, but eventually the rubber band gets like too long and it loses its elasticity. The sarcomeres of the myocardium are the same. So it can maintain that like forceful compensation for a while. And we want to catch it at that point with medications that take the stress off and help remodel it. But then it comes a certain point where the sarcomeres get so stretched out that even if we put them on all the right medications, treat the underlying cause, the damage is irreversible. Does that answer your question? So it's a spectrum. It's very much a spectrum and not like a hard, fast yes or no answer because it depends on when you catch them in their journey, if that makes sense. Excellent question. So that's tachycardic induced, usually has a good recovery. And then autoimmune diseases can also cause dilated cardiomyopathy, so sarcoid and giant cell. Dilated cardiomyopathy, how it presents is you could be asymptomatic for years and it's found incidentally. Sometimes this happens with routine screening in cardiology. Someone could be totally asymptomatic. They just get an echo for another reason, or they get like an MRI or something for another reason, and the ejection fraction is low, and that's what prompts the workup and treatment. Or sometimes they'll come to you with heart failure symptoms. So they'll come for edema, they'll come for shortness of breath, dyspnea on exertion. And that will prompt the workup. Sometimes they can present with VT and you get an echo and their EF is 30%. It can present with conduction disease or secondary mitral regurgitation. And unfortunately, sometimes these can present with sudden cardiac death from VT or pump failure. So I will also say, guys, the format for how we're getting you guys to get more and more familiar with EKGs is if there's an arrhythmia on here, I will expect you to know it for this test. The next test isn't going to be heavy on EKGs like the last one was, but if there's like a dilated cardiomyopathy and VT is one of the arrhythmias that can present with, I do want you to know and study that arrhythmia again so you guys have it down. So that would be fair game. Everyone's like, why are you doing this? But it's seeing EKGs over and over is how you're gonna know it. And now I want you to be able to put it in a clinical scenario like we've been practicing. And then diagnosis for this, you're gonna get an echo, an EKG, plus or minus a cardiac MRI. The cardiac MRI can kind of hint to you what type of like what's causing the cardiomyopathy. So if it's autoimmune, sarcoid might show up on the cardiac MRI. If it's scarring, that might show up on the cardiac MRI. We're going to do a cath to rule out coronary artery disease, right? Because how do we know when we see dilated ventricle if it's not ischemic? Yep.
Would dilated cardiomyopathy be different than like LVH?
Yes. So dilated cardiomyopathy is specifically like a thinning and dilation of the LV and sometimes the RV. So left ventricular hypertrophy is when the myocardium thickens. That usually is a diastolic preserved EF cardiomyopathy, but over time that could also turn into the heart poops out and gets weaker and now it's a systolic problem. But yeah, so it could like end stage lead to dilation, but for the sake of organizing it now, LVH, think preserved diastolic dysfunction. So again, we're going to get the cath to rule out coronary artery disease. That's the only way we're really going to differentiate this from ischemic cardiomyopathy. And if you can reverse someone's cardiomyopathy by putting a stent in or doing a CABG, we want to do that. And then labs for underlying etiology. So TSH, autoimmune, genetic testing. The treatment for this is guideline-directed medical therapy. Etiology specific treatment. So if it was alcohol induced, stop drinking alcohol. If it was cocaine induced, stop doing that. Treat the arrhythmia, start immunosuppressants. If it is autoimmune, and correct the thyroid, etc. Again, if the LVEF is less than 35% after 3 months of guideline directed medical therapy, you consider an ICD in this patient. So usually we give them 3 months of marinating in the guideline directed medical therapy before we put an internal cardiac defibrillator in. If it's end stage, we do LVAD cardiac transplant, same as before. And then we're also going to add family screening, not family screaming. They may be, but we're going to screen them and add genetic testing if it was positive for those patients. And this is when we talk about, when I mentioned internal cardiac defibrillation with CRT, this is what I'm talking about. So you could see here that we saw this before. This is a biventricular pacemaker with a defibrillator on the end. So what it does is it allows the heart to pace from both sides. So remember when we talked about left bundle branch blocks and right bundle branch blocks, how we can see the delay in the right and left ventricles because of that widened QRS. This therapy helps sync that up so the heart beats together, because that can also worsen a cardiomyopathy for a patient who has like an ejection fraction of 35%. Even if it's like a millisecond difference between the right and left ventricle firing, they don't have a lot of cardiac reserve. So they may not tolerate that well. And when we resync them up with this therapy, some patients get like a huge relief and their ejection fraction will improve. And this picture over here shows the left ventricular assisted device, the LVAD, and this is what those patients would walk around with, which is pretty wild. But I've seen patients actually live, the longest patient I've seen live with an LVAD was, I think, 2 years, which is pretty crazy. All right, any questions on dilated cardiomyopathy? For that one, so I would say fair game for this would be VFib, VTAC, monomorphic and polymorphic. I would say no left bundle branch block, because that can be the conduction disease that shows up with these patients. Those would be the main ones. And rapid AFib, in case it's a tachy-induced dilated cardiomyopathy. Yes.
That one went first.
Yes. Okay, so take home with dilated cardiomyopathy, EF less than 50%. It's basically anything can cause it other than valvular issues, hypertension, or coronary artery disease. Has a genetic component. The LV is dilated and thinned. And the treatment is very similar to ischemic cardiomyopathy, minus it has coronary artery disease. So next category is hypertrophic cardiomyopathy. This is primarily a genetic disease of the cardiac sarcomere. This is different than LVH caused by high blood pressure. This is like its own category. So asymmetrical LVH in the absence of another cardiac systemic metabolic disease capable of producing hypertrophy. So it's not going to be because of a valve problem that you see the thickened walls. It's not going to be because of hypertension. This is a genetic disease that happens with asymmetrical thickening of the LV. So the etiology is typically, the EF is usually preserved or hyperdynamic. So a hyperdynamic EF is an ejection fraction over 70%. So normal is 50 to 70, and there's a slide on this too that we go through all the EFs, is 50 to 70. Hyperdynamic is over 70%, and that's when the heart muscle is so strong that the EF is slamming. And in HOCM, that's what we see. So typically this is autosomal dominant. There's a lot of genetic variants that have been identified. And each offspring of someone that has this has a 50% chance of getting it. So we're definitely screening any children or direct relatives when we identify a patient with HOCM. And the pathophysiology of the obstruction, so you guys can see here. Oops, no you can't because I just flipped it. So this is a normal LV thickness on this side. You can see this is very severe hypertrophic cardiomyopathy. So usually it's in the septum. There's many different types of categories of HOCM. You guys will not need to know that, but just know that they exist. So two high-risk features of an obstruction are the septum and the mitral leaflet can cause transient obstruction into the aorta. So you could see here, this is a mitral valve. And if the septal wall becomes so thick, you can get something called SAM. So systolic anterior motion of the mitral leaflet. So this closes off blood flow when the mitral valve opens. And that could lead to syncope, hypotension, VT arrhythmias. So this is a high risk feature when we see this on an echo. Patients may present with no symptoms. We just find this on an echo. Or if we identified someone, their brother had it, they did screening, and that's how we found it. We're gonna have a harsh crescendo decrescendo systolic murmur that increases with Valsalva and decreases with squatting. And we may have an S4 gallop if it's severe enough because of diastolic dysfunction. They may present with heart failure symptoms, chest pain, syncope or pre-syncope, palpitations, or when young athletes have this, it could cause sudden cardiac death and they don't know it until they exert themselves and this happens. We diagnose this with a transthoracic echocardiogram. This helps us characterize the hypertrophy pattern to look for those high-risk features. We calculate an LVOT gradient. We look at the mitral valve to see if it has that SAM, systolic anterior mitral movement. And we look at the diastolic function of the heart. So EKG abnormalities are present in about 95% of these cases. So definitely know these. We may see LVH, repolarization abnormalities, like benign early repolarization, or LVH with strain, or left atrial enlargement. Because of those elevated pressures in the LV, the left atrium can get bigger. And what does that look like on an EKG?
It's a notch.
Yeah, like a notched P wave, exactly. In these patients, if they have high-risk features, you do want to do Holter monitoring to check for ventricular arrhythmias. And sometimes this is correlated with atrial fibrillation. We need to check 3 generations of family history. And a physical exam, we're doing provocative maneuvers with Valsalva, not just any provocative maneuver. We're doing Valsalva, decrease with squatting, and checking the murmur. Genetic testing and counseling once identified. And cardiac MRI is great if you're a specialist in HOCM. Usually they request a cardiac MRI. It sees the septum a lot better than the echocardiogram. Okay, and what's this EKG here? LVH.
Yeah.
Exactly. Write the criteria, you add the F in V1 or V2 with the tallest R waves in these leads, more than 35 millimeters, right? So the treatment for this, usually for cardiomyopathies, we were saying guideline-directed medical therapy. However, these patients don't tolerate vasodilator medications. And the reason is they need the preload. Because if you decrease preload, that LV cavity is already so small that you're gonna cause like slamming, like the two ventricles would be touching. And that is not good in these patients. That can cause syncope, hypotension, VT. The medications we treat with these, first line is non-vasodilating beta blockers like metoprolol and propranolol. You wanna slow the heart rate down. These patients don't do well with tachycardia and they don't do well with volume depletion. So caution with diuretics, no vasodilators, and we're starting with beta blockers with non-vasodilating properties first line. If that doesn't work, you can stop the beta blocker and start calcium channel blockers like verapamil, diltiazem. Of course, we don't want to use like the amlodipines because those have peripheral vasodilator properties. If symptoms persist, you can add something called disopyramide or a cardiomyosin inhibitor. If those medications don't work, then you can consider a surgical septal myectomy, which is the gold standard of treatment for HOCM patients that fail medical therapy, which is exactly what it sounds like. They take the septum surgically, open heart surgery, and remove a section of the septum to get rid of that obstruction. If they're not a candidate or they wouldn't survive a big surgery like that, there's another option called an alcohol septal ablation if severe symptoms persist despite optimal medical therapy. And this little cartoon shows that here. So it's basically a right heart cath, right? So they go through the femoral vein, up the vena cava into the right atrium to the right ventricle, and they insert a catheter that has pure ethanol on the side. Okay.
Yeah. Last semester, Gianna asked Dr. Lee, he was like, oh, can you just inject them with alcohol and make it, he was like, drink, and he was like, no, but I guess you can.
Well, this is also delineation because like in the ICU, no, they wouldn't do that.
Yeah.
But in my world, yes.
Thought about it.
I think-
Yeah.
Oh, he.
Yeah. And he's not wrong because you treat them with medication first. And that's like a newer, they're not doing that in the ICU. So he's not wrong in that respect. So this is a less invasive procedure if you're not a candidate for that. They put pure ethanol into the septal and eventually that area necroses off, which is pretty amazing. It does not have as high success rate as the surgical septal myectomy, but if this is your only option, like you wouldn't survive a huge surgery like that, it may be super beneficial in the right patient. If we identify genetically or on echo or on a Holter monitor that they have some high risk features that would correlate their HOCM with ventricular tachycardia or VFib, they're going to get a defibrillator, right? Our insurance policy to say, if you go into this, it's going to shock you and save your life. You may never need it, but we need to put it in because we know the risk. And this is hard for patients. Like when we would get HOCM patients, it's genetic. And if they, present like at a young age, a defibrillator, like it's life-saving, but it's like a big box. So like if you're wearing like a bathing suit or like things like that, you also have to like tend to that in a young patient because it's a lot for them. There's also something called a shock box, which is a defibrillator that doesn't have leads into the heart. It's literally like a little box that goes under the skin that shocks you. So that's like less invasive, but if you know someone has a cardiomyopathy, you kind of have less tools down the line. Like that just has shocking capabilities, whereas the internal defibrillator can be turned into a pacemaker. So you can change the settings, like if they ever need a pacemaker down the line or you need to add a lead to do CRT, that's the benefit of the internal one. Whereas the box is just like pads on the patient. It can't really do anything else. End stage is LVAD transplant, right? The heart poops out. We did all we could. It's not working. We see if they are a candidate for a heart transplant or LVAD as bridge to heart transplant or palliative. Any questions on that one? So take home, usually this has a preserved or hyperdynamic EF. It's an asymmetrical thickened septal wall. In the absence of any type of like other cause, like hypertension, valve issue, it's usually a genetic component. We do medications first. Then when we do surgery, if it's high risk features, we consider a defibrillator. We have restrictive cardiomyopathy, which is the least common out of all of the cardiomyopathies. This is when the myocardium, you can see in this picture here, it has increased stiffness. So it may or may not be a thickened myocardial wall in the LV. Sometimes it's just like more dense. The EF will be preserved. If this is late in their stage, you can get a low EF, the heart poops out, it can't compensate anymore, and the EF drops. But typically the EF will be preserved in restricted cardiomyopathies. Less than 5% of the cardiomyopathies you guys see will be this. And thankfully that's so, because the treatment for this and the prognosis for these patients is not great. The etiology, we have a couple more categories. We have non-infiltrative. This is like idiopathic, we don't know why, and scleroderma can cause this. Infiltrative, this is probably the most common that you guys will see if you work in like internal medicine or cardiology. Have you guys heard of amyloid yet? In cardiac or amyloid in like dementia?
Like Alzheimer's.
Yeah.
Amyloid.
So those amyloid plaques can also be deposited in the heart wall. And there's two types. There's AL amyloid and there's ATTR amyloid. AL amyloid is treated like a cancer. The mortality when you're diagnosed with that is 1 to 2 years. You get sent to hem-onc for chemotherapy. And ATTR amyloid has some newer medications that are progressing, like even in the, like currently they're really progressing in their treatment. ATTR is usually seen in elderly patients, and it can present like very vague symptoms, and sometimes it's very easy to miss because it can just look like diastolic dysfunction on an echo with like maybe fatigue and like some GI symptoms and like tingling, and they're older, so it's not clear cut. But that will usually have, amyloid usually has like a starry appearance on an echocardiogram. So it may or may not be thickened, but it will have diastolic dysfunction. And you may see like a starry appearance. I think it's called, no, never mind. Sarcoidosis can also cause this type of restrictive cardiomyopathy. Storage disease, so hemochromatosis, an abnormal deposit of iron, can also happen in the myocardium. Fabry disease is a genetic mutation where a certain protein deposits in the heart. Radiation induced, if someone had radiation to the chest for cancer or something, it can cause that. Tumors, drug induced, carcinoid can cause those. It may present with heart failure symptoms, most commonly right and left, because it doesn't really discriminate where the proteins or infiltrative process will deposit. 75% will present with AFib. That's a hint. I would know AFib for this test. Wait, really quick, because a lot of people got this wrong. What is the difference between AFib and multifocal atrial tachycardia?
It's just irregular, you must go breathe.
Yeah.
Difference.
Different P waves. Okay, I'm getting some. I'm getting some.
Three or more
There's no
P waves
and there's no P waves in
irregular.
it, yeah.
Yeah,
And the
Yeah.
multifocal has to be 3 different types of.
of P waves, but it's also irregularly irregular.
Yep.
And it will be fast. It'll basically look like AFib, but with 3 different P wave morphologies. That's what to look for.
So there's no,
What's that?
there's still P waves in multiples.
Exactly, exactly. But they're coming from all different parts of the atria. So AFib for these presentations, JVD, S4 Gallop because of the diastolic dysfunction, Kussmaul sign, which is increased JVD on inspiration because that increase in pressure in the RV. And how do we diagnose this? Echo usually has a normal EF with marked biatrial enlargement. Because the ventricles are so stiff and the pressure so high in the ventricles in diastole, the both atria will start to remodel and get bigger. You may or may not see increased wall thickness. You do lab tests for underlying etiology, amyloid, sarcoid, whatever blood work you're looking for. The EKG may also show low voltage, heart block, or some type of conduction disease. So you guys have seen low voltage on an EKG before? Okay, I will pepper that in too.
We learned about low voltage on PKG already?
No, but I thought
I'm like, wait, people.
that was a trick question. So low voltage, I don't have a slide up here, so I won't hold you guys to that unless I pepper it in to the next class, but low voltage is the QRS complex throughout the whole EKG will look small. So you know how some, like we have different R wave progression, all of that, it's all gonna look
Like
too
V1.
small. Yeah, everything's gonna look too short, like half of what the normal R wave should look like.
And then that's restricted. Then that's indicative of restricted.
It can be, yes, exactly. So if you have like diastolic dysfunction with biatrial enlargement and a low voltage EKG, you start to think this could be like amyloid, something restrictive. You can get a CT to look at this. An MRI, ultimately, you get a biopsy to definitively diagnose this. So the treatment is a poor prognosis overall, with limited treatment options. The 5-year survival rate is 65%. We target the underlying cause. AL amyloid has the worst prognosis. Usually with cardiomyopathies, to help remodeling, we treat it with the guideline-directed medical therapy. They don't tolerate it. They become hypotensive. They feel worse on a beta blocker. So it's really tricky to treat these patients. There's some medications now for TTR amyloid called tafamidis, which will stop this, will put the symptoms at bay, but it doesn't reverse anything. They're working on something now that actually will reverse TTR amyloid, which is pretty cool, but it hasn't come to market yet. Advanced disease, cardiac transplant. And then lastly, something called stress cardiomyopathy is referred to, also known as Takotsubo syndrome, which is also known as broken heart syndrome. So this is acute transient LV dysfunction with regional wall motion abnormalities in the absence of any coronary artery disease. What's pathognomonic of, is that how you say it? Do you pronounce the G? Okay. Pathognomonic. Okay. All right, I second guess that. Thanks, guys. So, is apical ballooning. So the reason why it's called Takotsubo is because it resembles an octopus, a Japanese octopus trap. So I guess this is what they use to catch octopus, octopi. And the LV will look like that. Like this is an LV gram on a cardiac cath. They shoot contrast dye into the LV and they evaluate its shape and also the squeeze. That's all the contrast you see here on the X-ray for the cath. And you could see side by side, it kind of does look like that. So apical ballooning is what you guys should remember. It mimics acute coronary syndrome and it's common in postmenopausal women. And the etiology is usually someone who just lost a spouse or grief or bereavement or a natural disaster. Acute medical illness as a physical stressor can cause this. Sometimes there's no identifiable trigger. The patients that I've seen with this, they do sometimes present as an MI. Like they will come in, they will have ischemic changes on their EKGs, and they will make a troponin, and we will take them to the cath lab. Their coronaries will be normal, or they'll have like 30 to 40% blockage, which isn't significant. And we do the LV gram, and it's apical ballooning, and that's how you diagnose this. The pathophysiology for this is catecholamine surges cause direct myocyte toxicity. So literally a broken heart stress can cause this.
How often do you see this?
I probably like over 10 years, I feel like I would see this maybe like once or twice quarterly. So like enough to like
Enough, but not.
significant, yeah. And they're treated like the same as a regular cardiomyopathy. They usually have great recoverment. Recovery. Recoverment is not a word, so don't use that.
Have you ever seen it in a population other than postmenopausal women?
You know what? I don't. Actually, yes. I have seen it in older male patients that lost their wives. Like big bereavement patients, but mostly women actually. So they're gonna present, you're gonna think that it's unstable angina or ACS. So they're gonna have chest pain. They could have shortness of breath, passing out, or heart failure symptoms. Sometimes they can present with cardiogenic shock. The EKG can reveal ST segment elevation, deep T wave inversions, ST depressions, right? All the ischemic changes we talked about. Ventricular arrhythmias, they can have QT prolongation as well. All of that is fair game. But you guys have this down already. The ischemic changes in the VT, I feel like you guys are good on. Yeah, all these guys up here. Yep. I didn't go off script. All up there. Their troponins may or may not be elevated. They may have an elevated BNP or a pro-BNP, natriuretic peptide. So you guys know what a BNP is at this point, right? So it's a peptide that the heart secretes when it's under stress. It can be elevated if someone's having an MI. If someone chronically has a cardiomyopathy, it could be a little bit elevated. If somebody is in fluid heart failure, it will definitely be elevated, usually over like 400. And another just caveat clinically, they won't test you on this on the boards, but you may see it on rotations, is that someone who's morbidly obese can have a falsely low BNP. So BNP isn't as specific with obese patients, which makes it trickier to treat. Stress cardiomyopathy, usually their EF is going to be less than 40% with apical ballooning, and they may develop an LV thrombus, right? Because if the apex specifically is the area that's dilated and not moving, blood can pool, we can get a thrombus there. So that's something you're looking for on the echo. The diagnosis is coronary. You're going to take them to the lab like they're acute coronary syndrome, and you're going to do an LV gram. You're going to see they have normal cores and the apical ballooning of Takotsubo. That's the gold standard of diagnosis as a cath. You're also going to get an echo. The treatment is empiric and supportive. the data for aggressive guideline-directed medical therapy is not well studied, but we still treat them with that. So we'll still put them on the 4 pillars, the ACE, the beta blocker, maybe aldosterone inhibitors, maybe SGLT2 inhibitors. We're going to diurese them if they're overloaded and put them on an aspirin. If they're unstable, or in shock, we can treat with ionotropes, vasopressors, mechanical circulatory support, and an intra-aortic balloon pump or Impella. Have you guys seen that before? An intra-aortic balloon pump? You have? Okay, I'm going to show you this video. Okay. So this is what they can put in the cath lab. They insert this during the cath lab, and this pretty much takes the pressure off the heart, takes the stress off the heart and pumps for it. So you can see there's a balloon in the aorta that's inflating and deflating, and it's pushing the blood. Oh my God, am I gonna get this? This is lecture 7 now. Okay. Okay, here we are. Thank you. So you could see the catheter, the balloon catheter is in the aorta, and it inflates and deflates. And at the foot of the bed, if you're in the ICU, you can adjust the settings for systolic and diastolic pressures. And it's basically pumping the blood to the coronary arteries for the heart to take the stress off the myocardium and kind of let the heart cool off after an acute event. So when we talk about balloon pump, that's what we're talking about. And now 4 hours later, I will find PowerPoint. Okay. Oh my God, guys. Okay. Okay, so now we're going to talk about heart failure. So you can have what we kind of talked about, all the categories of heart failure. You can have a cardiomyopathy without heart failure. Like someone can walk around no symptoms with an ejection fraction of 30% for a certain amount of time before the heart decompensates and you get signs of heart failure. So heart failure itself is a clinical syndrome with symptoms and signs that are caused by a structural or functional cardiac abnormality with elevated natriuretic peptide levels or evidence of systemic or pulmonary congestion. And that could be on exam. It could be radiographically. If you get a chest x-ray, a CT scan, they have fluid on the lungs, they have ascites. So this is a clinical diagnosis. Whereas a cardiomyopathy, it's structural and functional issues with the heart that are causing problems. But one can lead to the other. Cardiomyopathy can lead to heart failure eventually. There are some ways to, well, this is the standard way to classify heart failure symptoms and stages. And this you will have to know for your boards. And if you go into cardiology, internal medicine, you will also need to know these. So there are stages that we're going to go through. So the AHA stages are progressive and irreversible. So stage 1 is basically any patient that has like a risk factor. So if you have hypertension, diabetes, obesity without structural heart disease or symptoms, that's stage A. If you have stage B, this is pre-heart failure. So this is structural heart disease on echo. So we see structurally there's something wrong. They have a valve issue. They have a dilated LV. They have left atrial enlargement or elevated BNP, but they don't have symptoms. So they won't have shortness of breath. They won't have leg swelling, palpitations, anything like that. But we will see on echo that they have something wrong with their heart. Stage C is symptomatic heart failure. So we will see structural heart disease and they have heart failure symptoms, shortness of breath, leg swelling, all of that jazz. Usually stage C and D are what you guys are going to see in a hospital setting, right? Because they have symptoms, that need to be treated because they're overloaded and symptomatic. Stage A and B are usually what we see in the office, or if they're stable and compensated. Stage D is advanced heart failure. Stage D is the category that's you're going to be thinking about palliative heart transplant indications because we tried everything, their disease is advanced. They're having refractory symptoms despite optimized therapy. So we identified they had heart failure and a cardiomyopathy. We treated them with the guideline-directed medical therapy. We revascularized their arteries. We treated their AFib if they have it. We corrected their hyperthyroidism. And their EF is still low. They're still symptomatic. And now we're like backing off medications. Then we have the New York Heart Association functional class. So these are dynamic and they can change with treatment. So someone in stage C can have class 1 symptoms 1 week and then class 4 symptoms another week, depending on how compensated they are. So class 1 is they have no limitation of physical activity. So say they have an EF of 30, but like some of my patients that I've seen, they have an EF of 30. We see them in Home Depot and they're about to start a project and we're like, you shouldn't be lifting that, but that's possible, right? That's class 1. They're not limited. They just have a cardiomyopathy or something structurally wrong with the heart, but the heart is able to compensate for that deficit for now. Class 2 is slight limitation, ordinary activity cause symptoms. So maybe they can do their activities of daily life, but then when they go to walk uphill, they are feeling short of breath lately, or they, used to be able to walk up 3 blocks, and now at 2 blocks, they're getting out of breath. That could be a sign. Class 3 is marked limitation. So usually they're comfortable at rest, but activities of daily life, like getting up to take a shower, going to make themselves something to eat, they get fatigue or shortness of breath, some type of heart failure symptom. Class 4 is symptoms at rest. That's easy to remember. Class 4, stage D, isn't a good combination. That's usually a palliative transplant patient if everything's optimized already from our perspective. And I found this online. I thought it was relevant for the Knicks. Not that I want the Knicks to have any heart failure, but I'm like, it looks like it looks like the Knicks, like someone just made it. So I don't know. If you're a visual person, this is a visual of the classes for that. And I'm so happy about the Knicks, and I don't know why someone made this.
Are you going to the parade?
No, I'm working tomorrow.
Oh.
But I might be going to the city at night.
Oh,
So
that's tough.
yeah. What about you? Or you guys have and you have a test?
Yeah.
Yeah,
it was like-
A remote test from the parade? No, I'm just kidding.
Oh,
Just
but-
at 8 a.m. and then we have class at 8.
Oh, so you can make it?
They said
now
now
I
I
look
learned
at
to get there at 7.
100%. Definitely
Will
make
everybody
it.
get there
Do you
at
have
7?
anything Friday?
Exactly.
Like,
but it's
like
at 8 a.m.
Oh, man, who's so
Yeah,
no.
Oh, the Triple Crown.
I'm like, it'd be like,
You like a lot.
It's so hard. It's your Triple Crown. So I would say go.
Things like.
I would. I'm like, why did you guys argue? Weren't you so great? All right, sorry guys, back to that was a nice exciting break. I loved it. I'm not like a huge basketball fan, but my husband was telling me the story and now I'm like, I love these guys. I'm from New York too. They're so cool. Okay, so these you definitely have to know. It's all like scaled stages. You have to know that. This basically is just for those of you that like an algorithm format, it's the same things we just talked about. So these are the stages, A, B, C, and D. Usually stage C and D are the ones that are going to have symptoms, right? So patients move between the NYHA classes based on symptoms, right? So they can have class 2 symptoms and then say they have a provoking incident and they like eat Chinese food or they have like a heart attack and then go into fluid heart failure and now they're class 4. and they come to the ER, we have to treat them with diuretics, we have to optimize their medication, see what's going on, and then they go back to class 2. Does that make sense? And then we're also going to consider the ejection fraction. So I know previously, on the boards in medicine and in previous classes, we think about heart failure as systolic and diastolic, and that still is true, but heart failure has progressed so much to be so nuanced, that now they have heart failure, they call it heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction. Basically, it used to be like EF over 50 is preserved, EF under 40 is systolic, but then they were like, what do we do if someone's 41 to 49? And the answer is you treat them the same as systolic. You treat them as reduced, but they're in better shape than someone who's less than 40%. But they call it now, you guys will see this on rotations, and they may test you this on the boards, is mildly reduced EF is 41 to 49%. This group doesn't need a defibrillator, which is also a plus for them, right? Because usually less than 35% needs a defibrillator. Any movement in EF from reduced to greater than 40% is called heart failure with improved ejection fraction. So say you have someone come in and their ejection fraction is 30, and then we put them on all their medications, we fix their coronary artery disease, we fix their valve, we identify their hyperthyroidism, and then we repeat an echo in like 3 to 4 months, and their EF is 50. Hooray for everybody. And you're going to call it heart failure with improved ejection fraction. Okay, so I know you guys have heard the term EF thrown around a lot so far, right? Have you guys gotten into why, like, what is the EF yet?
Yeah, Dr.
Sort of. Okay, awesome. So this is just going to be like a mini review, but this just reiterates what normal and preserved is, 50 to 70, mildly reduced, we already said. Hyperdynamic is going to be over 70%. And how we get that calculation is from certain diagnostic tests. So echocardiogram, cardiac MRI is actually the most accurate assessment of EF and is the gold standard. So why doesn't everybody get a cardiac MRI?
Expensive.
It's too expensive and it won't be approved by everyone, everyone's insurance. Nuclear imaging, you're going to hear MUGA, nuclear stress test can give you an ejection fraction estimate, or a contrast ventriculography, also known as an LV gram on the cardiac cath. So usually if you get an echo and like say one, and they're very subjective, right? It's an ultrasound, someone looks at it visually, sees how it's squeezing, does a calculation. So it's tech dependent and it's also whoever's reading it dependent. And you guys will see sometimes like when you're in the hospital, you'll be like, oh, so-and-so is reading, everyone's low today, which like people tend to, some people overread, some people underread, and that can happen with an echo. So when that happens, to break the tie, you would get a cardiac MRI, right? To confirm what the EF is. And the calculation we use is EF, the percentage we get is stroke volume over left ventricular and diastolic volume times 100. This is the pressure volume loop, which we saw when we talked about valves before. I just put this here as a visual to demonstrate the effect of preload and afterload and contractility on the heart. We already covered this. If you guys want a little review, it's like 6 minutes, and this YouTube is really great if you're struggling with preload, afterload, contractility concepts. This is a great YouTube video to watch. But I just put that up there basically to think about the pressure volume loop again, and then think about how systolic heart failure and diastolic heart failure have compensated, have different compensations to move that pressure volume loop based on the changes of preload, afterload, and contractility that they'll have. We already kind of touched upon this. Current updated classification. This is another classification that they may ask you on the boards and you're gonna see in clinical practice is called the Stevenson profile. So when you go to evaluate a heart failure patient, we're making the diagnosis of heart failure. And then we're also assessing their volume status. And this is a way to communicate that to a team. So there's hypervolemic, which is they're fluid overloaded. There's euvolemic, which means they're right where we want them fluid wise. And then there's hypovolemic, they're too dried out. This actually categorizes that further to warm and dry, which indicates compensated heart failure, where the patient is properly perfused and has no congestion. There's a warm and wet profile. So this indicates the patient has good perfusion, but is still fluid congested and requires diuretics. The cold and dry, the cold and wet are both going to be low perfusion states with congestion. So cold and dry, they're going to have low perfusion without congestion. They'll just be like hypovolemic shock, and you're going to treat them with giving a little bit of fluid back. Cold and wet profiles is a low perfusion with congestion. This is characteristic of cardiogenic shock, where the heart pump is failing. And these basically B, L, and C, you are going to need diuresis. Cold, you're probably going to need like some type of ionotropic support, right? Because diuresis lowers the blood pressure. If you have a hypotensive, low perfusion patient, they may need a little bit of help, right? Crank up the blood pressure for them. Then I know Dr. Halimi touched upon this with you guys, so this isn't totally unfamiliar. We have compensated heart failure and we have decompensated heart failure. So compensated is a state in which the heart maintains adequate cardiac output and tissue perfusion through compensatory mechanisms, despite the underlying structural and functional cardiac abnormality. Decompensated is when those compensatory mechanisms become overwhelmed and actually start to worsen the problem, resulting in worsening symptoms of congestion, hypoperfusion, requiring urgent attention. So you guys can think about it as like, you're a PA student, you have an exam. You have 5 exams. You have to stay up to get the result you need on the test. You drink 4 energy drinks and you did great on the test. But if you did that over time for every single test, everyone's like, what's gonna happen? If you did that for every single test, you could have bad side effects after a while, right? So it's kind of the same thing. Yeah.
I have a question. So like,
How many?
no.
How many should we have?
No. So like, realistically speaking, energy drinks, they're obviously labeled as like bad and like they're not good for you over time, like you're saying. But what if you're just limiting it to like one? Wasn't that the same thing as like having a cup of coffee every day in terms of like caffeine
So I'm not sure because I don't drink energy drinks. The one time I did, I feel like I went into ATAC myself. So I know from the cardiology side, from a consumer side, I can't speak to that. I'm a big coffee drinker and I can't tolerate the energy drinks. From a cardiac side of like seeing patients, I have seen you can overdo it.
What's overdoing?
So it's different for everybody. Like for me, I probably have a half and I would go into SVT, but some people could drink 2 to 3 and like over time, and that would
What
go
about just like one in like the Hispanic male population?
I can't speak to that. It's really person dependent, but it is known to trigger arrhythmias.
Okay.
So be careful and make sure you stay hydrated.
I'll pass on the information.
To whoever you're talking about. Just caught like everything. Moderation is usually your safe spot. Some people are more sensitive, some people are less sensitive. Usually the people that I found would end up seeing us are people who work nights and drink them. And I think it's because like they're all thrown off. Like my sister, she's an ER nurse and she worked nights for like a very long time. Well, that's like the ER vibe is like, that's the ER water is the energy drink. So she went into like ATAC and she cut it out.
Hmm.
But everything in moderation, because I've also seen, caffeine can do the same thing, like everything in moderation.
Yeah, did you hear about the person that died a few years ago from the Starbucks thing? Oh no, the Panera. lemonade.
But they were drinking like
Yeah,
six
died.
a day.
Oh,
Yeah, to be
right,
fair,
right.
she had heart problems.
Right.
Yeah.
She had
She had heart problem, she had underlying problem.
Yeah.
Dang.
When she, when they-
Maybe
Yeah.
that was a sensitive analogy. Just kidding.
No, there were so many others.
But the point is that energy drinks are not known to be involved in this. That was just the analogy that I used. But
What?
the heart can compensate and has these compensatory mechanisms that we're going to talk about that help maintain cardiac output. Like it increases the heart rate, it increases cardiac contractility, it thickens the myocardial wall, and that will help someone be asymptomatic with underlying heart disease. But at a certain point, the heart will fatigue of that, and that's when you will get heart failure symptoms and a progression of that. So no one heard anything I just said, and they're like Googling, they're like, which energy drink, it's okay. I can't make a recommendation, but all I'm gonna say is that if you feel like crap after you drink it, then don't drink it.
Straight up tablets. Like it's probably.
Tablets, now we're gonna tap.
I remember being in this, I remember.
Tablets, but is that
Yeah.
better or worse for you?
So they're very concentrated. So I think a cup of coffee is like 200 milligrams. I think those are like 1,000 or like.
These are 200, they have 200.
Okay, they have, oh no, a cup of coffee is 90 milligrams. So, I can't say, I would say in moderation for emergency situations, and it depends on how you feel. Okay, wait, guys, we gotta get back, we gotta finish this up. We're back. Okay, so decompensated, the compensatory mechanism, is everyone all right back there? Good. Everyone's tossing their energy drink. So again, the mechanisms they have to maintain circulatory hemostasis, despite their impact function from maybe a cardiomyopathy or some type of underlying cardiac issue, are the following. So the Frank-Starling mechanism, neurohormonal activation, ventricular remodeling, and renal, sodium, and water retention. That one specifically will augment preload and circulating volume. So the body will hold on to sodium and water, which is where diuretics come in, right? So for preload, this is just another reminder that cardiac output is dependent on heart rate and stroke volume. Stroke volume is dependent on contractility, preload, and afterload. What are some examples of problems with elevated afterload? Hypertension, what else? Severe aortic stenosis, right? That can cause increased afterload. What about causes of increased preload? Sure, atherosclerosis. What about decreased preload? Yeah, dehydration, anemia, decrease your preload. Contractility, that's how well the sarcomeres of the myocardium are squeezing. So all of these play a role in compensating heart failure. So how the heart will compensate when someone has, say they have a low ejection fraction, they have a structural problem with the heart, the heart will increase the sarcomere stretch to increase end diastolic volume so that there's greater preload to make up for it. And that's fine, but like we said with the rubber band, you can only increase the maximum stretch of that sarcomere so many times until it becomes like a loose rubber band that loses its elasticity. Then there's something called neurohormonal activation. So this is the sympathetic nervous system, the renin-angiotensin-aldosterone system, the non-osmotic vasopressin release will all increase heart rate contractility, and peripheral vasoconstriction to maintain perfusion to vital organs. So that will be happening to help the heart compensate. And the person may not have any symptoms, except for maybe their heart rate's a little elevated, maybe their blood pressure is a little bit elevated. And this is very relevant when we talk about guideline-directed medical therapy, because this is what it's targeting. So when I worked in heart failure, my attending and he came up with this way of explaining to patients what this was. So we would try to educate them on why they need to take 4 medications every day, because nobody really wanted to do that. And it's basically what we would say was, we have this innate, like, evolutionary mechanism, neurohormonal pathway. We wouldn't say that to patients. I'm just saying that for it's like the patient's like, we have no idea what we're talking about. In our bodies to keep us alive. And how it used to work is, thousands of years ago, when we were like living in the wild and like our predators were like big woolly mammoths, saber-toothed tigers, we would maybe get bit by a saber-toothed tiger and we would be bleeding. And this pathway would activate because our heart would have less perfusion because there's blood, we're bleeding. That would signal to our kidneys low perfusion. And our kidneys would say, hey, we're bleeding. We need to stay alive until this bleeding stops. So it would increase the heart rate, increase peripheral vasoconstriction, increase heart contractility to help perfuse the kidneys because they're detecting our volume is low. So now, fortunately, we don't have a lot of saber-toothed tigers around that are biting us and bleeding, but we still have that pathway in us. So when someone has a low perfusion because of heart failure, it's a pump problem, but our body reacts the same way to keep us alive. So it's helping us in the meantime, but over time, that stress can actually kill us in the long run because the heart will start to get tired. So when we talk about guideline-directed medical therapy, we are blocking these pathways from happening to help the heart remodel and recover. So the angiotensin and aldosterone system, we're targeting that with ACEs and ARBs, right? That's gonna help take the stress off the heart, improve mortality rates. And same thing with aldosterone. We're targeting that part of this pathway in a different mechanism to help take the stress off the heart. And beta blockers, we're treating the increased heart rate that over time can cause the heart to poop out. And now there's a newer medication, you guys have heard, the SGLT2 inhibitors, the Farxiga and the Jardiance, which also, they're not sure the mechanism, but studies have shown that this has improved mortality rates in heart failure patients, regardless if they have diabetes or not, and also decreases hospitalizations, which is huge in heart failure patients because every time a heart failure patient gets admitted to the hospital, their chance of dying within the next year goes up 30%. So if you have someone that's a frequent flyer that keeps getting overloaded, keep taking a hit metabolically, and every time ends up in the hospital, it's not a good prognosis. So patient education is huge. That's why we use the saber-toothed tiger analogy. And when I first started out, he would tell me the story and I would like try to tell the patient, he's like, Lauren, let me take it from here. So the saber-toothed tiger doesn't come in, he's running, and I'm like, he's like, too many details here. But that just helps as a visual. This is a very complicated system, but that's how guideline-directed medical therapy helps remodel, take the stress off, and stops this maladaptive pathway. So that's why, even if someone, because patients will say, why are we not, like, why do I need to take these if I feel good and I'm not in heart failure anymore? And this is the reason why, because if their EF is 30 and they have no fluid on them and they have no symptoms, this is stopping that process. Another compensation is ventricular remodeling. So myocardial hypertrophy and chamber dilation can redistribute wall stress and preserve the cardiac output for a certain amount of time. So when we talked about valvular issues, we talked about a little bit about eccentric and concentric hypertrophy. So eccentric hypertrophy will usually present with a reduced ejection fraction. The wall doesn't get thickened, the sarcomeres get longer, and that leads to the dilation. Concentric hypertrophy is heart failure with preserved ejection fraction, and you'll see this thickening. So diastolic filling problems is the primary problem. And how will compensated heart failure present? So we refer to our categories that we saw a couple slides ago. So usually patients are typically New York Heart Association class 1 and 2. So asymptomatic at rest or a little bit of mild exertional symptom. They're stable. Their weight is stable. They have no peripheral edema and they have clear lungs. A point on the weight, have you guys talked about in any class, like taking daily weights for heart failure? So that is a monitoring tool that we could use as an outpatient, and also when we send patients home from the hospital, is weight gain. So this ties back to our lovely general review of systems, any weight gain, weight loss. This is a heart failure. We're looking for heart failure in a way. So if somebody gains more than, if someone's weighing themselves every single day, you can see like a 1 to 2 pound fluctuation here and there. You eat a little more, whatever. You like ate something salty, whatever. We educate heart failure patients that if they gain more than 2 pounds in a day and it stays on, or 5 pounds in a week, it's fluid. And to call us, because fluid comes on fast, whereas weight gain from just eating what you like often, and not exercising, that whole thing happens slowly over months. Yep. So it could be, yes. So compensated heart failure usually means that they've had symptoms in the past. They were treated with diuretics, they're on appropriate therapy, and now their symptoms are class 1, class 2. So they may have no symptoms, or they may have just their mild chronic symptoms. But the easiest way to think about it is on that scale. So they can move between scales depending on their volume status, depending on what's going on with them. Good question. So there's going to be adequate end organ perfusion, warm extremities, normal mentation, stable renal function, corresponds to the warm and dry, the profile A. And they're maintained on optimized guideline-directed medical therapy. Beta blockers, ACE inhibitors are, ANRI is its own class. This is Entresto. So head-to-head with ACEs and ARBs, Entresto actually decreases hospitalizations more and improves mortality, but it's expensive. So you want to put a lot of people on Entresto if they can tolerate it, but cost may be prohibitive, but you try to get them on it with free samples, things like that if they can. MRA, which are aldosterone inhibitors like eplerenone, spironolactone, and SGLT2 inhibitors, diuretics as needed. Diuretics are great for symptom relief. Being on a chronic diuretic does not change your mortality rate. It helps with your symptoms and volume status. Decompensated heart failure, we're talking about the adaptive mechanisms just became maladaptive. So we have sustained neurohormonal activation, like we talked about. This drives ventricular remodeling, fibrosis, reduced cardiac output, and worsening symptoms. These patients are going to have New York Heart Association class 3 through 4 symptoms. Their BNP may be rising. Their hemodynamic profile on that little 4-square chart is going to be Stevenson profile B, C, or D. So these are the patients that are going to come to you with worsening leg swelling, pulmonary edema, pleural effusions, ascites, JVD, things like that. And then you're gonna try to treat them to get them to the stable compensated state. Okay, so how this can present are dyspnea on exertion, shortness of breath, pulmonary rales, wheezing. Sometimes patients can get something called a cardiac wheeze. So you may not hear rales, but you may hear wheezing as the initial presentation. And you have to determine if it's wheezing from a pulmonary cause or if it's cardiac asthma. And that is usually, bless you, a clinical diagnosis. If you can also get a chest x-ray and you may see like curly V lines, some vasculature that's congested, some pleural effusion, and that may tip you off. Or they may have like a 5-pound weight gain or a 10-pound weight gain in 2 weeks, or peripheral, other signs of heart failure on exam. They could have an S3, S4. They might have murmurs and heaves, JVD, hepatomegaly, orthopnea, PND, edema, AMS, fatigue. They may have decreased urine output because of something called cardiorenal syndrome. Have you guys heard about that yet? So this is like if you go into internal medicine or like heart failure, this is going to be like the bane of your existence. But usually the kidneys like what the heart doesn't like, and the heart likes what the kidneys don't like. So the treatment, if someone has heart failure, the treatment is diuretics, ACE, ARB, ANRI, spironolactone, which all filter through the kidneys. When the heart gets overloaded, it can cause congestion and decreased perfusion to the kidneys, which could lead to elevated creatinine. So a lot of times you'll have, if someone's in heart failure, you'll actually have AKIs that get better with diuresis, but you don't know until you try to diurese them. So you could see someone with a creatinine of like 2.53 and you're like, I'm going to give a diuretic and see if it gets better, even though diuretics can be nephrotoxic. So they may, because heart failure affects the kidneys so closely, they may present with decreased urine output from an AKI. They may present with cardiogenic shock. This is a clinical diagnosis, so we need to take an excellent history and physical. If somebody has heart failure that was previously compensated, so they had no symptoms or minimal stable symptoms, and now they're in the hospital and they have fluid everywhere, class 4 symptoms, short of breath at rest, volume overloaded, JVD, orthopnea, everything, we have to take a history and do a physical exam to see what happened. Because basically these patients are so tenuous and require so much monitoring that anything can tip them off. If they get an upper respiratory infection, if they go on steroids that can retain sodium and raise blood pressure, if they take Advil for a couple days in a row, if they go into rapid AFib because of their changes, if they have pneumonia, if they have like a wound that's not healing. So if they're having another MI, they haven't had like a cardiac ischemic workup in a while. So taking an excellent history is so important with these patients because the devil's in the details. Like in the heart failure clinic, there was this one like 95-year-old man, his name was Martin. He was so cute and he had such bad heart failure. And he was 95, like he's not getting a heart transplant. He's living with this for the rest of his life. And he loved dirty martinis. Like every night he would have one. And me and the heart failure nurse were like, what can we do? Like, we can't take away his martinis at 95. Like, he's living his life. So we bargained with him and we said, you can have 1 olive instead of 3. And he stayed out of the hospital for like a year. So there's like, that can be the difference with these patients. They're so labor intensive because they're so tenuous. They have no cardiac reserve. They can't tolerate a lot, as opposed to someone with a healthy heart. So history is huge. What set them off? Why are they in heart failure now? How can we treat that underlying cause? Did they stop their Synthroid and like now they have hyperthyroidism and severe hyperthyroidism, we need to treat that. Did they go to Costco and eat a pizza? Because that was always one thing too. They're very sensitive to volume status changes. Or did they have a GI bleed and now they're anemic and the fluid shifts? So that is huge. I can't stress that enough. History in a heart failure patient. It used to be like systolic, diastolic, someone has heart failure, you give them diuretics, you send them on their way. But now it's much more nuanced than that, and patients do a lot better. We're going to get a chest x-ray, right? We can check for fluid that way, as we know. We're going to get a BNP. We're also going to get a pro-NT BNP. So a pro-natriuretic peptide. This is specifically for patients that are on Entresto. Your boards are not going to test you on this, but you are going to see this because Entresto is everywhere, and you're going to order a BNP, and it's always going to be elevated in someone on Entresto. So it's not going to tell you the information you need. You have to get a pro-NT BNP. It just checks a different pathway of a type of BNP, and it'll give you a more accurate assessment. We're getting a CBC, we're getting a CNP, right? Because we always want to know the renal function and the electrolytes in these patients. They're on diuretics, they're on potassium-sparing diuretics, they're on SGLT2 inhibitors, they're on ACEs and ARBs. All of those medications, as you guys know, directly affect electrolytes and kidney function. So we want to know that for sure. We're getting an EKG, right? We need to know if there's anything new going on arrhythmia-wise, CAD-wise, any changes. And we're 100% getting an echocardiogram. You may or may not need a cardiac cath if they haven't had an ischemic evaluation in a while and you think that CAD may be one of the causes that threw them into heart failure. That may be part of the workup. A cardiac MRI or further specific blood work if indicated. If we think it's like an infiltrative process or there might be something we can't see on an echo, we can get a cardiac MRI. We're going to separate the treatment between talking about goals for heart failure reduced EF and goals for heart failure with preserved EF. So for reduced EF, we want to identify and correct the underlying condition. We want to determine if they're compensated or decompensated, right? We have to say what class they're in. We have to say what stage they're in to be able to know when to intervene, where they're at in their disease progression. We're going to evaluate their volume status. Are they too wet, too dry? Are they warm and wet, cold and dry? All of those things we chatted about. Then we're going to eliminate the acute precipitating cause of the symptoms. If it was the Costco hot dogs, no more of them. If it was the olives in the martini, we're going to try to scale back for Martin. If there was a new medication that worsens heart failure that we found in our history, we're going to see if we can remove that. And then we're going to manage their heart failure symptoms, right? We have to treat their shortness of breath, their leg swelling. So we are going to diurese them. Modulation of that neurohormonal response, right? The saber-toothed tiger pathway. We need to start them on guideline-directed medical therapy, what they can tolerate, right? Sometimes there might be barriers to that. If somebody has a creatinine of 3 and hyperkalemia, we can't start a lot of these medications. If their heart rate is too slow, we may not be able to start the beta blockers. So you try to get them on the maximum amount that you can, patient specific. And we're trying to prolong long-term survival by the means that we chatted about already. So diuretics, we're going to identify what perfusion state they're in. Are they compensated or are they hypo perfusing, and do they need ionotropes to help carry them through when we're taking care of them with diuretic? Guideline directed medical therapy, aka the neurohormonal modulation. So this is why guideline directed therapy is so huge, and it's so important to educate patients on why they need to take these 4 medications, because they reduce the risk of death by 73%. in 2 years. So it's huge to get these patients on that to stop the neurohormonal modulation. And we already mentioned these before. So ACEs and ARBs or an ANRI, sacubitril and valsartan is what the generic name is for Entresto. Beta blockers. So the beta blockers that have been studied to improve EF, not all beta blockers improve EF. Oreg, metoprolol succinate, and bisoprolol are the beta blockers that have been shown to promote remodeling of the LV and reduce mortality. Aldosterone antagonists, SGLT2 inhibitors we talked about, and we're going to evaluate if they're a candidate for an ICD or CRT or LVAD or transplant. One other thing that I didn't mention before is that these positive ionotropic drugs, depending on the situation, we actually had some patients either as a bridge to transplant or as palliative care. You can put them on a continuous ionotropic drug drip, and we would manage it from the office. So they would have a PICC line in and a little bag that they would change out. We would teach the family members to do that, and they would continuously get milrinone at a certain dose. And I've had the longest patient I've had on that was 3 years. So it can give people a little bit more time, help with their symptom management as well. And the treatment goals of heart failure with preserved EF are a little bit different. So we want to relieve pulmonary and vascular congestion, address the correctable cause of impaired diastolic dysfunction. If they come in with like super high blood pressure, if they have underlying amyloid, if they have coronary artery disease, we're fixing these causes. Intensive blood pressure management for these patients. Vasodilators, which is kind of guideline-directed medical therapy on its own. ACE, ARB, MRAs, and possibly Entresto. Beta blockers can also be first line for these patients if they have an indication like coronary artery disease. Diuretics to diurese them, of course, and SGLT2 I inhibitors. Actually, this is a very new recent study. It used to be that spironolactone was indicated as reducing mortality in these patients. That's out now, and SGLT2 inhibitors have a better effect on diastolic heart failure patients for reducing mortality and decreasing hospitalization. It's a class 1 indication now. Tomorrow, it'll probably change, but for now, this is the latest indication. Right-sided heart failure, I will talk about because it's tricky in like the nuanced heart failure world now that usually the most common cause of right-sided heart failure is actually left-sided heart failure. So everything we just talked about, all the cardiomyopathies can eventually lead to right-sided heart failure, and then it becomes a mixed picture. This slide specifically talks about if you just have isolated right-sided heart failure, it's usually something called cor pulmonale from pulmonary hypertension. So right-sided heart failure alone, always think a pulmonary etiology. So acute PE, pulmonary hypertension, which has like 5 classes of its own. We're not going to go into that until, I think we go into that later, but not right now. And this is extremely difficult to treat because it's very susceptible to pressure changes. So if you diurese them too much, they can tank. If you put them on guideline-directed medical therapy, which they're all blood pressure medications, right? It's all the GDMT. So that could lower the blood pressure and then they can tank from that. So this is very tricky to treat and doesn't really have a great prognosis when someone develops right-sided heart failure. And then patient education. This is huge. This makes a world of a difference in this patient population. Multidisciplinary education program has been shown to reduce hospitalizations and all-cause mortality. You're educating them on disease understanding, right? Some people that have heart failure, they'll get to our clinic and they don't know that the mortality rate can be 3 to 5 years. So referring them to a heart failure clinic or having that conversation with them if it's appropriate. Medication management, you guys see they're on a lot of medications. They usually have a lot of comorbidities, making sure there's a system in place that they can take these, there's someone to help them. You're educating them on when to take them, what side effects to look for, and then the daily weight monitoring. Usually we tell patients, get a scale, stand on the same scale every day. And then if you notice 2 pounds in a day or 5 pounds in a week, call us and then we'll adjust your diuretic. Or sometimes you have a 15-pound weight gain in 2 weeks and then they end up in the hospital with that much fluid. And the rule of thumb is if it took 3 months for fluid to accumulate and then end up in the hospital, probably going to be in the hospital for like 2 weeks. Symptom recognition. We counsel the family. You'll have them in the office and you'll say, look, this is pitting edema. Check their legs every day. He gets a cough when he's going into heart failure. Call us if that happens. Comorbidity management. If their diabetes is out of control, if their obesity is getting worse, those are things that managing those are going to help their heart failure as well. And dietary counseling, right? Costco martinis, eliminate those or have them sparingly. Sometimes we tell patients if you, if you're going to eat something salty, maybe take an extra water pill the next day. And remote monitoring and telemetry monitoring. They've come a long way with how we can monitor these heart failure patients. There's at-home blood pressure cuffs, pulse ox, scales. There's agencies that have a nurse come to the house once a week. There's also something called a CardioMEMS. It's newer in like the last 15 years, but it's a device where they do a right heart cath and they put a sensor in the pulmonary artery. And then they have the patient go home after the procedure. They're sent home with, we call it like a pillow, and they lay on it, hit a button, and we get a live reading of what their pulmonary artery pressure is. So we can see before they have symptoms if they need extra diuretics, which is great in the right candidate. If they don't have Wi-Fi, it can't work. If they're like too obese and the sensor wouldn't work, they're not a candidate. If they can't be on blood thinners, they're not a candidate. But one story, we had a big Greek population at our office, and there was this one guy, he went to Greece for like 6 months of the year, and we would check his CardioMEMS from Greece. And we'd be like, did you have gyro again? And he'd be like, I did. And we were like, take an extra diuretic, and he'd be in Greece. But he'd do really well. So it's come a long way with monitoring these patients. And that makes the biggest difference with keeping them out of the hospital and helping with that high mortality rate and frequent follow-up. Okay, now we have a case and then we're almost done. Oh, nice, we're right on time. Okay, guys, so we have a patient who's been short of breath for a few months. Respirations are 16. Blood pressure is 142/92. The pulse is 99 beats per minute and regular. Temperature is okay. O2 is a little bit low, 92% on room air. So this is a 54-year-old male with hypertension, presents to the clinic with intermittent episodes of dyspnea on exertion. So dyspneic episodes are worse with exertion, especially when walking up the stairs. There's no chest pain, but he admits to orthopnea and paroxysmal nocturnal dyspnea. We do the physical exam. He has 2+ pitting edema of the lower extremity and rails. We hear 2 out of 6 systolic murmur, best heard at the apex radiating to the axilla with no JVD. And this is his EKG. So let's go back just based on this. What are you guys thinking? So class 3, worse with exertion, especially when walking up the stairs. I would say class 3. And we're thinking heart failure, one, because this is the heart failure lecture, and two, because of the physical exam findings, right? That he has pitting edema, he has rails, and there's a murmur. So we're suspicious of heart failure right off the bat. So I would say if this is heart failure, this is class 3. If this plugged into the acute coronary syndrome lecture, it could also sound like an MI too, right? Worsening dyspneic episodes could be an anginal equivalent. So I want you guys to think that way too. So what do we think this is? LVH, right? It's like dripping off the page. We don't need to calculate the boxes. Normal sinus rhythm with LVH. So what are you guys thinking with LVH and hypertension? Could be heart failure preserved EF, could be reduced EF, depending on where this guy is in his phase, right? We could have hypertrophy, which was helpful, but maybe his EF dropped. So we need more testing, right? This doesn't give us the full picture. So we got a chest x-ray. What do you guys think of the chest x-ray?
Large.
Cardiomegaly. This is a little fluffy, right? We have some curly V lines, increased pilar vasculature over here. It's a little congested, probably what we're hearing with the rails. What else do we want to order? 100% echo. What else?
Labs.
Labs, which ones?
Uh,
CBC, troponin, yeah, right? We don't know if this is MI heart failure. Yeah. And also heart failure, this could actually be type 2 demand, right? If someone comes in for a heart failure exacerbation, that's stress on the heart. If it's not a real MI, it could be type 2. I think you guys all got that on the exam. I was very proud. So the echo results show a dilated LV, ejection fraction is 32%, moderate MR, and some segmental wall motion abnormalities. So now what do you guys think? What's that?
Would need the figure.
Defibrillator, maybe. So the defibrillator isn't something, I don't know if I clarified this. The defibrillator isn't something you'd get from the jump. You would need to put them on guideline-directed medical therapy, give them a shot for their ejection fraction to recover. So we usually let them marinate in the GDMT for 3 months, and then we'll repeat the echo. And if it's still less than 35% and they're on like the best medical therapy they can be on, then we would put in the defibrillator. But we give them a chance for their EF to recover first, unless they have like VT or something else going on. The moderate MR, do we think that's secondary MR? Yeah, right? Because it's dilated, so the annulus probably pulled apart, and now they have the mitral regurgitation murmur. Some segmental wall motion abnormalities. Do we think maybe they could have had an old MI, right? Sometimes we will see that it present like this. Someone has high blood pressure chronically. They present with heart failure, and maybe the underlying reason was an old MI. But we're going to take an excellent history. We're going to ask new medications, anything salty, any palpitations. Have you started any new medications or anything like that? And would you guys want, what would the treatment be for this patient? What's that? Diuretics is 1000%, right? We got to get them euvolemic. His blood pressure is stable. So this guy would probably be what class? C, he has structural abnormalities to the heart. And then the New York Heart Association classification was 3, right? Because 4 is, what's that?
2.
So 2 would be symptoms, like minimal symptoms. This was like he's walking up the stairs. So this is his daily life. So that would be class 3.
Typical to class 3 and C go together, do they match up usually?
Yeah, that's the stage that's gonna bring someone in, right? Because they have significant symptoms. The goal is to treat them with diuretics and GDMT and different therapies that we talked about to get them back to like a class 1-2 symptomatology. So yes, I would agree. Stage C, New York Heart Association, class 3. And what would we want to do for this patient? So diurese them, and then we took a history. Nothing's really jumping out. No like salty foods, no steroids, no new medications, no arrhythmias. So what do we need to do next? So that brings up a great point. So beta blockers are indicated. You don't want to give someone a beta blocker in an acute heart failure exacerbation because it can cause bronchospasm with the pulmonary congestion. You may be able to start the ACE-ARB or ANRI. You could possibly start the SGLT2 because it has a little diuretic in it. And you can also start the aldosterone inhibitors because those also have a little diuretic effect if their kidneys can tolerate it. Some people, you give them a diuretic and their kidneys go crazy and you don't want to go too fast. But once they're euvolemic, like once you get all the fluid off, definitely a beta blocker. So we'll do diuretics. The 4 pillars we're going to start pending the clinical picture, pending what the creatinine is going to let us do. Beta blocker will start after we get all the fluid off. I would do an ischemic workup on this patient because of the segmental wall motion abnormalities and the MR. Candidacy for an ICD in the future, like we talked about, we're going to make sure they're on optimal medical therapy, wait 3 months, give the heart a chance to recover, and then reevaluate for ICD if their EF doesn't get better. Do they need ionotropes? This guy looks okay with his blood pressure and multidisciplinary patient approach. One more question, then we're out of here.